Good afternoon. My name is Esther Bron, and today I will talk about automated volumetric MRI tools. I have no financial relations to any of the AI companies mentioned. And in the light of this symposium, I, of course, would like to talk on AI for diagnostics in a memory clinic. And I here want to highlight the need for clinical validation studies. So previous talks already highlighted why it is needed, what are the needs for diagnostic AI in the memory clinic, and what are the technologies being developed. And a lot of technologies are there, but they're not reaching the target memory clinic yet. And I think validation studies play a big role in that. So what technology are we talking about? We're talking about machine learning to integrate multidimensional, multimodal diagnostic information. So based on large-scale MRI data, but also integrating clinical data, cognitive testing, and lab test data to help the diagnosis of dementia. So for example, to make a classification between Alzheimer's disease patients and cognitively normal controls. So this is a large research field with over 1,000 publications, which really took off from 2008 onwards, when data started becoming available. So recently, a big survey study, a big systematic review was done by Borchert et al. From the DEMON network, which is now in preprint available. And we systematically analyzed many papers in this field and showing what the state of the amongst others, what the state-of-the-art performance was, and that is around an area under the curve of 92%, which is quite high. But despite these high performances, it is not yet being used in clinical practice. And as said, I want to demonstrate the need for validation studies, and I'm going to demonstrate that based on an AI technology that is being used in the memory clinic, and that is AI for quantification of MRI. So traditionally, MRI in the memory clinic is being used to exclude other causes than neurodegenerative diseases that cause a cognitive impairment. So for example, a stroke. But since quite a few years already, MRI can also be used to get more insight into finding the underlying etiology, finding the cause of the dementia. So, and that is mostly done by a radiologist highlighting specific patterns of atrophy and estimating the severity of vascular brain lesions. And in the future, by integrating the high dimensional aspects of imaging, so picking up even more subtle patterns, there is potential for a diagnosis even in a more early or prodromal stage, and predicting conversion to dementia in mild cognitive impairment patients. But currently, MRI is mostly used to detect patterns of atrophy and severity of vascular lesions, and this is done by a neuroradiologist, a visual assessment of the MRI scans, and for that also to make some sort of standardization quantification, visual rating scales are used. So for example, the medial temporal atrophy score, which gives a rate to the atrophy rate in the hippocampus and medial temporal lobe. There is a tendency now more to use quantitative assessment of MRI. And this is a technique that uses machine learning, that uses AI to get automated tissue segmentations to extract the volumes from the MRI scan. So to segment white matter, gray matter, and CSF, and compare those volumes to the volumes of a reference population. And for example, using those reference curves in which for the quantification, a radiologist or a clinician can automatically take account of the age of the person, and the sex of the person. So there recently was a survey by the European Society for Neuroradiology to assess which memory clinics, which neuroradiologists actually use such quantification. And it turns out that the majority does not. Some of them always do, or in specific cases, and they use hippocampus volume or total brain volume. but the majority does not. And the reasons for not doing so are that they don't have the software available, that it might be too time consuming to use such a software, or they don't have the expertise to do so. But the reasons for doing it, so there are pros to using quantitative assessment of MRI. So the first one is that it is automated and reproducible. So it doesn't depend on the mood of the radiologist, time of the day, experience of the radiologist. And in a couple of years from now, we would get, based on the same scan, the same result. And also it's pretty straightforward to take account of age and gender, for example, because of this comparison to normative data. But there's also some cons. So that it may take extra time because it might not be integrated in the standard clinical workflow, and also the added value of these quantitative assessments for the actual diagnosis of the person, that there's lack of evidence for that. But regarding software availability, there's actually quite many providers of such software. And this availability is increasing. Availability of this software was a reason for my colleagues from Erasmus MC in collaboration with University College London to do this systematic review of available software packages. So they included softwares, a total of 17 that were FDA approved or CE marked. For inclusion in the study, they should target neurodegeneration. They include automatic brain segmentation step and comparison to normative reference data, and they should output as a report for the clinician or the radiologist to use. And they evaluated those methods based on the Quantitative Neuroimaging Initiative framework, based on 3 categories of evidence, and that is first, the technical evidence, so the technical validation, and this technical validation is what the software needs to be FDA approved or CE marked. And that is, does the software what it promises? So scan, rescan, comparison with manual segmentation and with the state of the art. So that's the technical validation. One step further is the clinical validation. So how does it actually impact the clinical management of a patient? How is this diagnostic accuracy, and how does it, for example, compare to visual ratings? So that's clinical validation. And the last step in this evidence is the evaluation of in-use or the workflow. So what is actually the benefit to the patient of using such software? What is the effect on reporting time? So factors like that. So those were evaluated. So they looked into all papers that provided evidence for the software being available. So, and of the 17 companies, of the 17 tools of companies, 11 had a technical validation paper published, and 7 of them had at least one clinical validation paper published. And on the right of this slide, you see the total number of patients, and the majority are indeed technical validations. But what is most striking, that there's no workflow or in-use validations published, at least. And what is then the impact of this quantification? So does this quantitative assessment of MRI improve diagnostic accuracy? And there's actually quite limited data on that. So the work that is there suggests a modest improvement of diagnostic accuracy and the confidence of radiologists. But the results seem to be dependent on what type of diagnosis we're looking at. They seem to be dependent on the rate or the radiologist experiments, and they differ per software depending on the learning curve, so how easy it is to get to use that algorithm. So then coming back to these pros and cons. So these software are indeed automated and reproducible and make comparison taking account of age and gender because of this normative data easier. But apart from that, information is lacking on indeed, is it more consistent across levels of experiments? We don't know yet. And also integration into the clinical workflow is not evaluated, and we don't know it yet, whether it indeed improves the clinical and diagnostic efficacy. So in conclusion, I think we can conclude that AI for MRI quantification has high potential benefit in the memory clinic, but available tools need more evidence of real-world application, so we need more clinical validation studies. And I think this is also important once we start combining with AI this MRI information with all the clinical information to make diagnostic tools. Then we also need these clinical validation studies to be able to use them safely and have them benefiting the patients. So thank you very much. I want to thank all my collaborators and want to thank you for your attention. Thank you very much.